Good evening, everyone. I'm Don Liacano. I'm the program manager at NAMI Davidson County. This is our collaborative education session with Vanderbilt Behavioral Health. I have with us Tracy Glasgow, representing Vanderbilt Behavioral Health. Tracy and I worked during the year to get at least 4 ed sessions collaboratively with the Vanderbilt staff. This is our 4th of the fiscal year. We will be discussing further ed sessions for the next fiscal year, 2024-2025 soon. I encourage anyone, and if you know someone, to email me at outreach@namidavidson.org if you have any suggestions for education sessions. This one on psychosis tonight has been very popular. It's actually set a record for most registrants in the 3.5 years I've been at NAMI Davidson. So we do listen to our members and the public about what they want, and you all wanted something focusing on psychosis, so here we are. So without further ado, I want to turn over the program tonight to Dr. Stephanie Hall, and she'll go through her presentation, Improving Our Understanding on Psychosis. So here you are, Dr. Hall.
Thank you, Don. I'm going to share my screen here. Let's see. All right, you guys able to see that okay? Okay, perfect. All right, so as was already mentioned, I'm Dr. Stephanie Fall. I'm a board-certified psychiatrist at Vanderbilt University Medical Center, and I work within the Vanderbilt Psychiatric Hospital. I primarily work with individuals who are experiencing psychosis, and I work with adults, so age 18 and older. I focus my practice mostly on individuals who are experiencing their first episode of psychosis, but I also care for individuals who have experienced psychosis for much longer, and really enjoy getting to know the patients, getting to understand their symptoms, determine how to best treat them. My work also involves working a lot with family members of individuals who have psychosis. So I speak with families a lot, providing psychoeducation on psychosis, how to best support their loved one who's going through a psychotic episode, and really try to kind of walk with my patients and their families as they're going through this process. It can be a very overwhelming, confusing process, and so I try to provide as much education and support as to what to expect. And I really enjoy learning about psychosis. I enjoy sharing what I know. In general, the field of psychiatry doesn't know everything that there is to know about psychosis, so there's a lot of gaps in our understanding, but we definitely know some things, and so I'm happy to be here tonight to talk with you guys about what we do know. And like was already mentioned, happy to take questions at the end of the presentation, so keep those questions in mind, and we can go through that at the end. See if let's switch the slide. Okay, so on this slide, I'm just wanting to kind of lay out the groundwork of the presentation and what you can expect to hear tonight. So we'll first go over defining psychosis. What even is psychosis? Can we have a shared definition for that term? Then we'll go through the symptoms of psychosis. We'll talk a little bit about the experience of psychosis from the patient perspective, family's perspective, and the provider perspective. Personally, I'm coming from the provider perspective, so I can talk about that from a personal standpoint, but I can also share just what I've heard from patients who have lived experience, what it is like, and then also sharing what I've heard from families who have experience with their loved one going through it. We'll talk about diagnoses associated with psychosis. It's important to note that psychosis is not a diagnosis in and of itself, so we'll talk a little bit more about that. We'll go through some of the treatment and management of psychosis, barely touching on it. Honestly, there's so much more to go into, but we'll touch on that. And then at the end, we'll talk about long-term recovery and prognosis. So this is some information that I give to patients and their families in the hospital setting when maybe they're going through their first episode and they're really asking me, what should I expect going forward? What may my life look like a month from now, a year from now? And what are things that are actually within my power, within my control to try to improve my prognosis or my recovery going forward? All right. So to start off with, and really trying to think of the definition of psychosis, what even is psychosis? It seems like defining psychosis should be simple, but it's really not. There's not one definition of psychosis that is like the shared definition that we all use. Some are much more specific. Some definitions are more broad. I personally prefer the more broad ones. I think it's more inclusive. And I really like this one from the National Institute of Mental Health that provides the definition as psychosis refers to a collection of symptoms that affect the mind, where there has been some loss of contact with reality. During an episode of psychosis, a person's thoughts and perceptions are disrupted, and they may have difficulty recognizing what is real and what is not. So you can see in that definition, it's not saying exactly what types of symptoms of psychosis or how long the symptoms are present. There are some definitions that will say that psychosis must include both delusions and hallucinations, but this is really a more kind of broad definition saying that there's some type of symptom of psychosis is present that is interfering with someone's ability to have contact with reality, and they may have difficulty recognizing what is real versus what is not. It's really important to note that not all psychotic experiences represent a mental illness. So psychosis does not equal schizophrenia. Psychosis is not synonymous with schizophrenia. You can't use these terms interchangeably. One symptom of psychosis are hallucinations, including auditory hallucinations, which are hearing voices. And it's known that up to 1 in 10 individuals in the general population will experience voice hearing at some point during their lifetime. And they may not be diagnosed with a mental illness at all, and they may not be diagnosed with a psychotic disorder at all. It's also really important to note that psychosis can look very different in different people. Although 2 people can be diagnosed with the same type of psychosis, like 2 people can be diagnosed with schizophrenia, they may not have the same set of symptoms. There's a lot of what's referred to as heterogeneity. So there's a lot of variation that we see, both in the types of symptoms, the severity of symptoms, response to treatment, and long-term recovery, prognosis. And we'll talk a bit more about some factors that may help to explain that down the road on another slide. So just to go through some statistics, like how common is this even? It's difficult to know the number of people who experience psychosis, but psychotic episodes are not as rare as you may think. There's some studies that estimate that between 15 and 100 people out of 100,000 will develop psychosis each year. Psychosis most often begins in young adulthood, so late teens to mid-20s, and the average age of onset is 24. And we know that in the US, about 100,000 teens each year will have their first episode of psychosis. And overall, 3% of people in the United States will experience at least one psychotic episode during their lives. And so this equates to schizophrenia impacting about 1% of the general population worldwide. To put this in perspective, bipolar disorder impacts about 1 to 2% of the general population, and major depressive disorder impacts about 5 to 10% of the general population. So not as common as depression, but most people are actually pretty surprised when they hear how common it is. All right, so now we'll go through some of the symptoms of psychosis, and I have it here separated into positive symptoms and negative symptoms, which you'll see sometimes if you hear people talking about psychosis or if you're reading about symptoms online. And it's really important that we all understand what it means by positive versus negative. So positive in this situation doesn't mean good. Positive really means that it reflects an excess or a distortion of normal functioning, whereas negative doesn't mean bad, it just means that there's a diminishing or an absence of normal functioning. So Positive symptoms, something is added in or distorted. Negative, something is removed or diminished. Positive symptoms, I have them listed there. We most commonly, when we're talking about psychosis, most commonly people will think about hallucinations and delusions. That's what we hear. People are most familiar with. Hallucinations are perceptual disturbances that involve your senses. So sight, sound, smell, touch, taste. All senses can be distorted in a way that you can have a hallucinatory experience. Auditory hallucinations, so the voice hearing, are the most common type of hallucination that we see in schizophrenia. And it's about 70% of patients with schizophrenia will experience auditory hallucinations. So these can be voices that they're hearing. It can be one voice, it can be multiple voices. The voices can be talking amongst themselves. The voices can be commenting on what the individual is doing throughout the day. The voice can be commanding in nature, can tell the individual to do something or to not do something. The voice can be more negative or derogatory, saying really mean things about the person. And as you can imagine, that can be any type of voices can be very distracting for the individual, can prevent them from being able to focus in conversation with other people in front of them, can be difficult for them to focus on their work, their studies. It can be difficult for them to fall asleep at night if they're just constantly hearing these voices distracting them. Delusions are strongly held beliefs that are not true. So it's and the belief is not a part of one's culture, and almost, everyone around them recognizes that this belief is not based in reality. So delusions, there's a ton of different types of delusions, but again, most commonly what we see in schizophrenia is a persecutory type delusion, and that involves an individual feeling persecuted against. So someone is after them, they're feeling targeted, harassed, followed, manipulated in some way, and that goes along with what is commonly referred to as paranoia. There's other types of delusions. So these fixed false beliefs, other types of delusions can include religious delusions, grandiose meaning like I'm larger than life. So believing that they, hold some position of power or authority that maybe they don't. An example could be like, I'm king of the world. A religious delusion can be, I'm Jesus, or I am, I am the Son of God. Other types of delusions can include delusions of like romantic type delusions, like erotomania. So this can include someone believing that another individual is in love with them or meant to be with them when that's not reciprocated. And oftentimes we see that with like celebrities. So someone may say that, here in Nashville, someone may say Taylor Swift, is in love with me and we're meant to be married. So that can be a form of an erotomanic delusion. There's a lot of different types of delusions. Disorganized speech involves speaking incoherently, responding to questions with unrelated answers, saying really illogical things, or shifting topics frequently. And I'll often refer to this with patients and families as like scattered thoughts. And so in talking with patients, once you can identify, it's helpful to identify kind of shared language when speaking about this. And I've found that with disorganized speech, if I can ask an individual, are you feeling like your thoughts are more scattered today? Sometimes that can help to point me in the direction that they're still experiencing some disorganized thoughts or speech. Disorganized behavior can manifest in a variety of ways. It can include odd or bizarre behavior, purposeless or ambivalent behavior or movements, random movements, intermittent and random unprovoked agitation. It can also present like childlike silliness. They can present in a disheveled way or dress in an abnormal or unusual way. Or it could even involve someone showing inappropriate sexual behavior. Catatonia is a group of symptoms that can involve an abnormality of movement and behavior. So oftentimes it can involve a lack of movement, a lack of communication, repetitive or purposeless movements, intermittent agitation, confusion, restlessness. Some people who experience catatonia will not be able to respond, not be able to speak to others around them. They may hold their body in an unusual posture for a long time. They may, again, have this repetitive movements that are referred to as stereotypies or mannerisms. They may mimic someone else's speech or behavior. And they may resist people trying to adjust their bodies. So there can be this rigidity of their extremities, of their arms and legs. Negative symptoms overall. So again, negative meaning that these symptoms are diminished, or there's an absence of normal functioning. So the first one there listed is emotional flattening, and that can refer to restricted emotional expression. So they're just maybe their facial expression is not showing the wide range of normal emotions that they typically would be showing. They might just look a bit more flat. Motivational impairment can also include just a reduction of goal-directed activity. So they might just seem kind of amotivated. They're not doing as much kind of progressing forward in their life. And that can include kind of larger life goals, but that can include even like day-to-day, like being able to, have the goal-directed activity of taking a shower today may not be there as much. They can have a reduced sense of pleasure, so they may not actually experience pleasure as much as they would have otherwise. So if they typically really enjoyed going out to the movies with friends, maybe they're not going to want to go out to movies with friends as much, because when they go, they don't experience as much pleasure from it as they did previously. Along those same lines, there can be social withdrawal, so the individual may not have the desire to be around other people. They may really prefer to keep to themselves. And then reduced speech, sometimes referred to as alogia, is just a poverty of speech or reduced speech output. And oftentimes this is also referred to as poverty of thought. So there's just not as many thoughts going on as would have otherwise. So to touch on the experience of psychosis, both from the patient and the family perspective, and then the provider perspective. So patients have often described the experience of psychosis to me as isolating, frightening, confusing, frustrating, and disintegrating. It's a really difficult experience, especially in a first episode of psychosis, when this is all very new and confusing and they don't really know what is going on. They don't know what's going on themselves. They have a difficult time just figuring it out to themselves, but then it's even more challenging to even describe what it's like to others. And so it makes it really impossible for them to feel understood by others, because they're not even able to fully understand it themselves at times. By the disintegration, I'm often, in this case, referring to what's known as an anxiety disturbance that can happen with psychosis, where there's a breakdown of one's core sense of self. So there's a breakdown of their fundamental sense that their own experiences are actually true to themselves, that their experiences are their own experiences. And that can cause a lot of confusion and a break of trust, and really being able to know what is theirs, what experience is actually theirs, where kind of they end and others begin, type of thing. I oftentimes think about the early times of psychosis as very isolating, because with all these experiences, people can feel, again, like it's difficult to both trust themselves and others. And so that's going to cause someone to withdraw into themselves more and become more and more isolated in that sense. And it's important that we as providers, and in educating their families, that we're trying to encourage them to speak and share with us their experiences as best they can, even if they're struggling to find the right words to describe the experience. From the family perspective, families will often describe the experience of their loved one going through psychosis as overwhelming, scary, saddening. Parents of young adults, in particular, will often express to me that they feel as though they're grieving their child. They'll feel as though they're having a lot of guilt around this, that maybe I should have done something or could have done something differently in their childhood that could have prevented this, or maybe I would have done something differently if I would have recognized the onset of symptoms sooner. Maybe things would be different now, type of feeling. And so I see it in my job to provide a lot of education to parents around psychosis and hopefully relieve some of the burden and guilt that they carry and instill more hope. From the provider perspective, I really see this as a really rewarding area of psychiatry to work in. It's not a common area of psychiatry to work in. Most psychiatrists are not focusing on the treatment of psychosis, but I find that it's an opportunity to make really meaningful connections with patients who are going through a very difficult time in their life, to help them navigate it and to help families best know how to support their loved one going through psychosis. We know that there's not a cure for psychosis, but there is really good treatment. And so we can make a difference in helping individuals going through this experience. And it's really rewarding to be able to see patients feel relieved of their symptoms, feel like they have more control or ownership over their experiences, and find, a path to recovery that, makes the most sense to them. Okay, this slide is going over the diagnoses that we see associated with psychosis. And this is a very broad overview, so it's not all inclusive. I don't think I can include all of the diagnoses associated with psychosis on one slide, to be honest. But I created this kind of layout just to share with you kind of how I think about psychosis, especially when I'm working with a young adult who's experiencing psychosis for the first time, or just really anybody experiencing psychosis for the first time. And we're trying to differentiate where is it coming from. So the best way that I can describe to think about this is to separate it into primary and secondary psychosis. On the right side of the screen, the secondary psychosis really can then be broken down into what I think about it as medical disease, neurologic disease, or substances. I'll briefly go through that, and then we'll spend the rest of the time on the primary side. So and let me back up. So secondary psychosis is really a term that is used to describe symptoms of psychosis that are actually caused by a known medical, neurologic, or substance that is causing the psychosis. Whereas the primary psychosis is psychosis that is due to a mental illness, due to a psychiatric illness, such as schizophrenia. And we'll go through that a bit more. But the medical illnesses that can cause or promote psychosis, there's a bunch of them. This can include metabolic disorders. This can include abnormal thyroid functioning, multiple sclerosis. There's a lot of lupus. There's a lot of different conditions that can cause a secondary psychosis. From the neurologic side of things, we can see psychosis in patients who have had strokes, patients who have had like serious head injuries or concussions, people who have had brain tumors, people who have epilepsy or seizures can also develop psychosis. And then by substances, I mean both illicit substances, but also medications. We know there's some medications that we prescribe for other reasons that can increase someone's risk of experiencing psychosis. And that can include just such as steroids. So if steroids are used to treat a condition, that could, lead to someone experiencing psychosis if they are vulnerable to experiencing psychosis. Substances can also include illicit substances, such as marijuana can promote psychosis in some individuals. Stimulants, both prescription and non-prescription stimulants. So thinking about medications to treat ADHD, for instance, Adderall, Vyvanse have been shown to promote psychosis in some people, or illicit substances like cocaine, methamphetamine can also promote psychosis. So when we're seeing someone in my job in the hospital, if I'm seeing someone with new psychosis and I'm trying to figure out where it's coming from, it's really important that we do a medical or neurologic workup that includes a physical exam. It includes a lot of lab work, lab testing. It sometimes can include imaging studies, like getting a picture of their brain through a CT or a brain MRI, to really, essentially what we're doing is ruling out any of these secondary causes. Making sure that, in their history, we're not identifying something that could promote, psychosis due to, being a medical, neurologic, or substance. If we're able to rule all of those things out, we're not identifying anything that could cause a secondary psychosis, then we're kind of left with it. It's a primary psychotic illness. There's different phenotypes of psychosis as well that can point us more in the direction of a primary versus a secondary psychosis. But really, if we can't identify anything that would point towards a secondary, then we're kind of left with a primary. And then over on the left side of the screen, looking at the primary psychosis, we can really then separate those into either affective or non-affective. And what I mean by affective is mood. So an affective illness includes like bipolar disorder, major depressive disorder. These are mental illnesses that involve major mood disorders like depression and mania. So if we're saying that someone is having psychosis in the context of a major mood episode, they likely have an affective psychosis. If they're experiencing psychosis in the absence of a major mood episode, it's more likely going to be in the schizophrenia spectrum range. I didn't include all the different diagnoses within the schizophrenia spectrum range, but I'll just briefly mention that if someone has psychosis that lasts at least a day, but it's less than a month, we classify that as brief psychotic disorder. If they have symptoms that last at least a month, but less than 6 months, we classify that as schizophreniform disorder. If they have symptoms that last at least 6 months, that's when schizophrenia can be diagnosed. There's also a condition that's called schizoaffective disorder, and this involves a major mood episode concurrent with psychosis, but then they also have psychosis present for at least 2 weeks or more in the absence of a major mood episode. So it's kind of like an in-between between schizophrenia and bipolar disorder. Okay, so what even causes psychosis? The long and short of it is we don't know. We don't have a exact cause that has been identified. And the reality of it is that most really studies have shown that it's a combination of both inherited genetic factors and external environmental factors. So it's not just one thing if we're talking about that primary psychosis, right? The secondary psychosis, we can identify its cause, but the primary psychosis, we don't know where it's coming from. There's some type of combination, though, between these inherited genetic factors and the external environmental factors. The image on the right of the screen really shows that, over time, someone may be born with a certain genetic loading that increases their risk for experiencing psychosis. With time, maybe environmental factors, contribute. And then again, over time, their jar becomes full and they have enough risk factors that pile up that their jar then can reach the threshold of psychosis becoming prominent. And this is a way in which I'll oftentimes describe it to patients and family members, that some people just come into the world with their jar partially full, whereas others come in with it not as full. And that is due to genetics. What there's some interesting twin studies that have been done that show that identical twins who, have then identical DNA, if one develops schizophrenia, there's about a 50% chance that the other twin will develop schizophrenia. So that goes to show that it's not all about the genetic factors, right? Because if it was, then 100% of the time, the identical twin would develop psychosis. So we know that genes do play a role in psychosis, but they're certainly not the only factor contributing. Genes that make proteins that are involved in sending messages in the brain have been found on different chromosomes, and a gene with a mutation can produce proteins that are made incorrectly or sometimes not made at all. And there's some mutations on genes on certain chromosomes that have been found to increase the risk of someone developing psychosis. But the research has shown that each of these genes is really thought to increase a person's vulnerability to psychosis by a small proportion. So again, even in what we understand about the genetic factors, it's not like a specific gene mutation has been identified to be the bulk of the cause of psychosis. We know that genes are involved. We know that certain gene mutations can increase someone's susceptibility, but we don't fully understand how they work or how this all really pulls together. We know that the environmental factors are still a huge part of the play at whether or not psychosis presents. Interestingly, some of the environmental factors can really even start at birth. So if someone has a difficult delivery at birth, that's an environmental factor that can increase their risk of developing psychosis or schizophrenia down the line. Being born in the winter months can increase someone's risk of experiencing psychosis. Being born and brought up in a large city, metropolitan area, being an immigrant can also increase someone's risk for psychosis. Childhood traumatic events in childhood can also increase someone's risk of experiencing psychosis. Going through a serious head injury, having a TBI, going through really stressful life events can increase a risk of psychosis, and then having a history of substance use can also increase the risk of psychosis. And so again, there's more environmental factors than what I just listed, but it's important to note that it's really the genetic and the environmental factors coming together. Oftentimes what we see in the hospital setting when someone's coming in with new onset psychosis is they have this underlying genetic factor, maybe, and they have a first-degree relative with psychosis. And then there's been recent things in their life that have come to add on these stressors that then make the final push. So it might be, they're graduating from high school and moving away for the first time to go to college. And that's an exciting time of life, but it's also a major stressor. Maybe they're using substances for the first time in their life. Maybe they just went through some other type of traumatic experience that can then be identified as maybe one of the final triggers to push them into the psychosis. And in some cases, we can't really identify any immediate trigger, and it's come about just when it's come about, and there's nothing specific as to why right then did it come about. Starting to talk about the treatment and management of psychosis, I'll first say the treatment really depends on what type of psychosis are we talking about. So again, if we're talking about the secondary psychosis, we're going to be needing to see what was that underlying cause. Was it caused by recent substance use? Was it caused by recent use of a medication that can promote psychosis? Is it caused by the medical condition? Whatever it might be, epilepsy, really trying to figure out that root cause and focusing on treating and reducing that root cause. They may still require treatment with an antipsychotic, but it really needs to be focused on what the root cause of the psychosis was. Primary psychosis, treatment of schizophrenia involves treatment with medications and therapy. And so we'll be going into more detail about that in just a bit. When we're thinking about the treatment and management of primary psychosis, I think it's often really important to talk about the phases of psychosis. So we recognize 3 phases of psychosis. You can see in the image on the right. So that includes the prodrome, the acute phase, and the recovery. Most of the time, psychotic symptoms, in the case of a primary psychotic episode, these symptoms are not occurring out of the blue. Almost always, a psychotic episode is preceded by this gradual, non-specific changes in a person's thoughts, perceptions, behaviors, and functioning. And this is referred to as the prodrome or the prodromal phase. So during this period of time, the person may have some of these subtle changes, but they're not going to have the clear-cut psychotic symptoms. That won't come until the acute phase. The prodrome phase can include someone feeling disconnected, having changes in their mood, feeling more anxious, feeling more irritable. They may start to have some suspiciousness. They may desire to be alone more. They may have trouble with focus and concentration. They may find that maybe they're not hearing voices, but they're noticing that sounds around them are just louder and more distracting. And they may start to have some trouble with work or school because they're not able to focus as well, or they're preferring to withdraw and kind of be on their own. And the confusing part about the prodrome phase is that what I just described can represent a lot of different psychiatric illnesses, right? So some of what I described could seem like ADHD, could seem like a major depressive disorder, could seem like an anxiety disorder. And so it's really difficult when someone is in that prodrome phase to recognize it as a prodrome of psychosis, right? But it's important that we're working to identify psychosis as early as possible. So some work is being done to really identify individuals who are at high risk of experiencing psychosis when they're in that prodrome phase, to try to intervene then and hopefully prevent them from experiencing psychosis, or at least reduce their risk of having a really severe psychotic episode. Also, when we're thinking about the treatment and management of symptoms, we have to think about the different levels of psychiatric care. So when we refer to outpatient versus inpatient care, we're referring to essentially clinic versus hospital-based. So if someone really, we prefer to keep people out of the hospital as much as possible, want them to be, be able to be at home living their life and then come in for periodic appointments, right? But if there's ever safety concerns, that's when we're really looking at the need for hospitalization. And safety concerns can include that someone, is at risk of harming themselves or others, and that may be due to, like thoughts of actively hurting themselves or others, but it could be due to severe disorganization that's really putting them at risk, right? That they're not in full control of their actions, such that they're putting themselves or could put themselves and others at risk. And sometimes a hospitalization is needed to really figure out what is going on when things have come on really suddenly, for instance, and there's a lot of questions around where is the psychosis coming from. We can do a pretty thorough and in-depth medical and neurologic workup pretty quickly in the hospital setting, get someone stabilized on medications so that they're at a stable enough place to then transition to outpatient care. Whenever we're thinking about treatment of any type in psychiatry, I always like to mention the importance of shared decision-making. So we're not making decisions on behalf of our patients or their families. We're really wanting to work together. You're an expert in yourself and your experiences and your symptoms, and we're, an expert in the treatment of psychosis, and let's come together and find an individualized treatment plan that makes the most sense for you at this time. I'll talk a little bit more about coordinated specialty care. That's specifically referring to the treatment of first episode psychosis primarily. And then obviously medications and psychotherapy are really important, and I'll mention the medications on another slide. The psychotherapy piece can be referring to both individual and group therapy, but primarily talking about the individual therapy. There's cognitive behavioral therapy for psychosis, and there's also recovery or oriented cognitive therapy for psychosis. And really the goal of these types of therapy is to allow a person to have both better understanding of their symptoms, how to manage their symptoms, and have better control over their symptoms. It's also about promoting normalization and validation of their experiences, reducing stigma, providing them with healthy coping strategies, helping them to modify their maladaptive beliefs, and allowing them to, again, develop these adaptive strategies to cope with symptoms in a healthier way, so that maybe they're not having to lean on as many of those maladaptive coping strategies that they may have. Okay, so on this slide, I'm just wanting to kind of point out a little bit about antipsychotic medications, and there's so much more that could be said. But you may hear people refer to antipsychotics as first generation versus second generation agents. And that also you can hear that referred to as typical versus atypical. First generation literally just is referring to they were identified first, and then second generation kind of identified second. So there are differences between the two. We see more and more in modern day practice that second generation agents are used oftentimes more often than first generation agents, and a lot of providers will use second generation agents first in working with an individual experiencing psychosis before moving to a first generation agent. Some examples of first generation antipsychotics include Haldol, droperidol, thorazine, fluphenazine, loxapine. Second generation agents that you may have heard about include aripiprazole, olanzapine, risperidol, Invega, Seroquel, Geodon, and clozapine. I'll talk a little bit more about clozapine, but there's really no evidence that shows that first generation or second generation agents are actually like more effective than the other. There's just a difference in their side effect profile that really can impact which medication is selected for which individual. So we know that first generation agents can come with a higher risk of EPS or extrapyramidal symptoms, and that can include the long-term risk of tardive dyskinesia, which is a movement disorder that we can see individuals develop after being on antipsychotics for months or years. Second generation agents tend to come with a higher risk of metabolic disturbances, which refers to like weight gain, increased risk of diabetes, increased risk of hyperlipidemia, or like high cholesterol. It really, there's still a good amount of variety though within these classes. So there are some second generation agents that we know don't have as much of that risk of metabolic side effects. Some of these medications in both classes can come in a long-acting injectable form, meaning it's an injection that's administered intramuscularly in their arm, in their thigh, in their buttock, that can be administered over a periodic time course, right? So it can be, depending on the drug, it can be every 2 weeks, every 3 weeks, every 4 weeks, every 3 months, every 6 months. And this allows an individual to not have to take the pill every day. And it can come in an injection form that's particularly helpful for people who struggle with taking a medicine by mouth consistently. So a lot of times when we're working with someone both in the hospital or in the clinic, we'll be starting them on a medication that comes in the tablet form, making sure, number one, that they tolerate the medicine okay, that they're not having an allergy or a major side effect to it right away. And we also want to see that they're having some response. So they're having a reduction in symptoms and they are reporting, feeling better on the medication. We would want to confirm the tolerability and the effectiveness before giving the long-acting injectable. Clozapine is actually a second generation agent. It's widely referred to as a gold standard for treatment of treatment refractory schizophrenia. So individuals who have been tried on other antipsychotics and have not had good responses. They haven't had a good reduction of symptoms. They've had ongoing symptoms that are really difficult to treat. We would think about clozapine. there's actually some evidence that really we're not using clozapine enough, that we are waiting too long to use it. It's really effective, and we should be thinking about it earlier on in someone's treatment course. We also have to remember, though, that clozapine comes with a lot of potential for side effects, and some of them are pretty serious, and it requires pretty close monitoring. So for the first 6 months that someone's on this medication, they have to go to a lab and have their blood drawn once a week to follow a particular lab that's checking to make sure that a type of their white blood cell count isn't dropping, because it could increase their risk for infection if they were to have this white blood cell start to drop. There's a lot of other side effects that we see with clozapine. So some people really struggle a lot with these side effects, others not so much, but ultimately it is a very effective medication. And it's one that I do end up using a good amount on patients who just really haven't had as good of response to any other agent. Clozapine does not come in a long-acting injectable form. So the individuals do have to be pretty dedicated to taking the medication consistently and going to these really consistent lab appointments. Because if they were to miss a lab appointment, they, may have to restart clozapine at its low dose and redo the titration. That's a pretty slow process. There's so much more that can be said about antipsychotic medications, but I'll leave it at that. And then if you have questions at the end, we can talk more. A little bit more about coordinated specialty care. Coordinated specialty care is really the standard of care for treatment of first episode psychosis. It's an evidence-based, recovery-focused, team-based model that really allows the provider who's an expert in treating psychosis, and the provider can be a psychiatrist, a psychiatric nurse practitioner, a psychotherapist, to then make decisions with the patient and with the patient's family to really provide wraparound care and services. And the National Institute of Mental Health has supported a lot of research on this to show that the coordinated specialty care programs are very effective, and that there's 5 core components that are listed here. And so that includes the individual and group psychotherapy, that includes family education and support, really getting families involved and providing educational workshops to make sure that they understand what psychosis is and how they can best support their loved one experiencing psychosis. The case management side of things to really make sure that the patient's life is addressed from a lot of other aspects, whether it has to do with housing or access to, health insurance. Medication management will be done by the medication provider, and talking about the use of antipsychotics, as on the last slide. And then the supported education and employment services. So that really focuses on what is the individual's goal. Are they wanting to get back into work or school? And then this individual is able to help them in doing that, and help them in maybe applying for that job and even accompanying them to the first interview, or helping them apply for college. And then maybe once they're in college, getting assistance when it comes to maybe having adaptive services, to make sure that they can have extended time on test or whatever type of assistance that they're needing to be successful in their education goals. When we're looking at long-term recovery and prognosis, we can go through a list of positive prognostic factors, and then you really can flip these to then tell you what the negative prognostic factors are. So some of which an individual has control over and some of which they don't. So being born a female sex, that is a more positive prognostic factor. Having your psychosis be of that acute onset and not having that smoldering psychosis or the prodromal period beforehand. Interestingly enough, having a confusional state associated with your psychosis is a more positive prognostic factor than if there is no confusion. Having a lack of the negative symptoms is better. A lack of substance use is better. High premorbid functioning, meaning prior to the onset of illness, the individual, was high functioning in their academic, career, social aspects of their life. Having good insight referring to their understanding of having a mental illness, their recognition of their symptoms, and then strong social supports. And that really is where I can pull in the families, and saying, you all being here and being involved in your loved one's care is a positive factor for them. It's showing us that they, have the supports going forward that can help them during this really challenging time, help them, with normalizing the experiences, with making it to appointments, with remembering to take medications, and really trying to instill, hope and positivity. Also, when thinking about prognosis, I'll refer to the rule of thirds that you may have heard or read about before, but basically 1/3 of patients who have experienced psychosis will just have that one single psychotic episode during their lifetime and no others. Their functioning is not impacted. They don't have psychosis again, though we'll say you're at risk of having psychosis again. There will be 1/3 of people who just won't. They'll have one episode and that's it. Another 1/3 will experience psychotic episodes and maybe recurrent psychotic episodes, but they'll recede. The symptoms will reduce and go away maybe entirely, and they're not going to have much of an impact on functioning. So they'll have preserved psychosocial functioning. They'll still be able to, manage their work, their relationships, their life, and they won't be impacted too much by the recurrent psychotic symptoms. The third group will have psychotic symptoms pretty continually, pervasively, and they're going to suffer significantly in terms of a deterioration of functional of their functioning. So that might again include social, occupational, employment, and just general independence and being able to, care for themselves. They may notice a reduction in that. And it's one of the more challenging parts of my job is really trying, when I'm seeing someone in that first episode of psychosis, really trying to figure out who may fall into which category, based off their positive prognostic factors. Am I able to tell who may fall into the category of having just a single episode and no others? Am I able to say, based off of having this symptom or this severity of symptoms, that they are falling into that third category of having more serious symptoms and a more serious reduction of functioning? And sometimes, yes, we can have a better sense as to maybe this bucket or this bucket is more likely for this individual. But oftentimes, it's impossible for us to say for certain where an individual will fall, and really it's only time will tell. I'll oftentimes really promote with patients and families, really thinking about what they have control over and focusing on that, instead of spending too much time on trying to predict the future or focusing on these things that are in the past that we can't change or that we don't have control over at this point, right? And so trying to focus on things that can be done right now. A common example of that is reducing substance use. We work with a lot of individuals who will come in and, the marijuana that they're using may not be the cause of their psychosis, right? They don't have substance-induced psychosis, but it's certainly contributing and is not helpful at reducing and at reducing their psychosis and promoting recovery. And so helping individuals understand what they have control over and helping them to accomplish those things, such as reducing substance use, reducing marijuana use, maybe replacing it with a more adaptive coping skill, can be really helpful and effective. So what does recovery even look like? It's really different for everyone. It's very personal. There's no one clear-cut path to recovery. And for each individual, it's often not a straight line. So there's ups and downs in the road. Ideally, the ups and downs are still moving in towards positive recovery, but sometimes it's a more clear, trajectory than for others. Recovery for a lot of people can look like gaining a sense of control over their psychosis, and that reduces their level of distress. So just having a sense of, I have control over the voices that I'm hearing. I can decide when to listen to them and when to not. That automatically can give people a sense of relief, and that they are just not at the whim of whatever psychosis is deciding for them that day. Recovery can also look like having a restored sense of self. So kind of having that restored sense of, like I know who I am, and I'm feeling more like myself again. I'm feeling less disintegrated and more integrated. I'm feeling back to my like core self. Recovery will also include making lifestyle changes that support their overall mental wellness. That often will include reducing or stopping substance use, focusing on sleep, focusing on mindfulness strategies to reduce, stress and anxiety. Recovery will also look like oftentimes the illness is no longer the dominant part of their everyday life. It becomes more secondary. They're able to focus on all these other things more. They may also have a restored sense of social confidence, and they're able to talk to people more confidently, engage in relationships, feel more comfortable back in social settings. Along those same lines, being able to function in going to school or working and feeling more confident in doing that, and also performing better, getting the better grades or moving, ahead in the workforce in a way that they were wanting to. It can also look like establishing independence as a young adult. It's really tricky that psychosis tends to come about in that young adulthood, right? So I said the average of being 24, that's a time when people are really individuating and trying to figure out who they are and where they are in the world and what they're wanting to do with their life. And then when psychosis hits, it really can stunt that development. And so once gaining control over psychosis and in a stage of recovery, the individual can get back to what am I wanting, and how am I wanting to live my life? What are my goals? And really then gaining that sense of independence and going on their path forward in life. So when we're looking then at the future of psychosis, because I mentioned at the beginning of the presentation that, we don't know everything about psychosis, but we do know some stuff. We don't know everything when it comes to where psychosis is coming from and exactly its cause and exactly the best way to treat it based off the specific causes. But when I think about, people will ask me, where's the field going to be going 5, 10, 20 years from now? And I think a lot of movement is towards identifying those high risk groups and intervening early. And so there's a lot of focus on figuring out who may be in the high risk group, who may be in that prodromal period, and trying to have interventions that can help reduce an individual from moving from that prodromal phase to the active phase of psychosis. Is there a way to stop it from progressing, or is there a way to lessen the impact that it may have on them? We're also going to be hopefully identifying the specific genes that increase a person's vulnerability to psychosis. And that may help us to better diagnose the different types of psychosis. If there are different genes and mutations associated with different types of psychosis. That can also help us better understand the biological mechanisms that underpin psychosis, and that can then lead to very specific individualized treatment plans based on genetics. So if you have this specific gene mutation, this is the type of treatment that will be most helpful for you. And then I also see that there may be advances in psychotherapy. Again, I see it probably focusing more on the recovery front. Recovery-oriented cognitive therapy that's come out in recent years is very focused on not only the typical CBT tactics that have been used historically, but on the individual's recovery and what does recovery look like for you. And so again, it's all very individualized. That's kind of how I see the treatment of psychosis progressing. And that is the final slide here, the end of my presentation, but we still have plenty of time for questions or comments. So I'll go ahead and stop sharing if that's all right. And then we can go through questions. If people have questions about like a specific slide, I'm happy to open it back up to go back to a slide, but
Well, thank you, Dr. Fall. Dr. Fall, we do have about 25 minutes, so we do have time for questions. I'm going. My first question is that your cat or just a random cat in the PowerPoint?
that is my cat.
Making an appearance.
Yes, his name
All
is
right.
Jody.
Yeah. I'll get it started. And everyone, if you want to raise your Zoom hand or put it in the chat, Eileen and I will ask questions for you. You can ask for yourself. But I was going to ask Dr. Fall two questions. One that was already in the chat. Can you be misdiagnosed with psychosis when you have epilepsy?
That's a really, really good question. There can be misdiagnoses made. I always want to provide the caveat that I think providers are going to be making the diagnosis the best they can at that moment with the information they have, right? So it's important that if this individual who has epilepsy, if the epilepsy preceded the psychosis, that should be something that's identified then when the provider is obtaining a history, right, and understanding what medical or neurologic history the person may have. And then if epilepsy is brought up as part of their history, doing additional testing to really see have active seizures been present, and are there symptoms of psychosis kind of matching the timing of when they've had their active seizures. Can both schizophrenia and epilepsy occur at the same time in the same person? Yes. So it's possible to have both, and that may then not be a misdiagnosis. But it is important to make sure that the specific types of epilepsy that are known to be associated with psychosis, that those are ruled out. So one in particular that we'll often think of is temporal lobe epilepsy. That's a specific type of epilepsy that is known to have associated psychosis. But I worked with plenty of individuals that have both epilepsy and psychosis, and it can be tricky to differentiate, but it's possible. And then oftentimes going forward, combining outpatient psychiatric care with outpatient neurology care, and having the neurologist and the psychiatrist communicating and talking about their treatment plans is helpful as well.
Thank you, Dr. Falk. I'll ask one more question, and there's some in the chat. I'm curious. I'm someone with lived experience. I've never had psychosis, as far as I know, and I think I would know if I had. I do have intrusive thoughts, but I always steered clear of things when I was younger. Psychedelics, LSD, things like that. I did do copious amounts of alcohol. I did smoke cannabis, etc. But I always steered clear of LSD because I was concerned that something might happen and I would never come back. I'm asking one, is there a higher risk if someone takes psychedelics? And I know that it's been more in the news lately of bringing back psychedelics in therapy, like before it was illegal. Like I know the anecdotal references that Cary Grant did over 50 trips with his therapist in the 50s. Is that something that is still being worked on, or do people have to be careful if there's psychosis in their family history, even to think about that type of therapy?
Yeah, that's a really good question, something that we get a lot. I'll bring it back to the image of the genetic and the environmental factors that impact vulnerability for psychosis. So there's people that will use psychedelics or other substances and never experience psychosis in their life. And there's others that will use the same amount and experience psychosis that may be life altering. And so oftentimes then it has to do with what other factors were at play, right? So that can have to do with genetics. So if an individual does have particularly a first-degree relative who has a psychotic disorder, I think it would be, helpful for them to know that and to then take that into consideration when they're deciding if they're going to use various substances, because they may have a higher chance of developing psychosis than someone else using the same substance who doesn't have that family history. Not all substances carry the same risk for psychosis. Certainly psychedelics are one that can promote psychosis, whether it's a short-acting brief psychotic episode or whether then it progresses into a schizophrenia. Again, there's so many different factors at play that will determine that. There's a lot of studies being done on, like you said, using psychedelics in the setting of psychotherapy. And I can't comment too much on that. It's not something that I do specifically. I don't know the details of it. But I know that there's evidence out there that it's used in a very controlled manner in the stage, of psychotherapy, and it's viewed as safe in that way. But I would venture to say that that's not out of the question that psychosis couldn't come from that.
Proceed with caution.
Proceed with caution. And really, when I'm seeing patients, they've already experienced psychosis, right? And so what I will talk with people about is, if you've already experienced psychosis before, whether this is your first episode, and we don't know if you're going to fall into that 1/3 that will have one episode and never again, just knowing that going forward, you are at risk then of experiencing psychosis again. And so take that into consideration, as you're making your decisions with what substance you choose to ingest.
Okay, thank you, Dr. Paul. I'm going to go to the chat, and we've got a question. What do we know about brain activity from current imaging that would show a difference between hearing voices and subvocalization?
I don't have the information on that, to be honest with you. I'm not sure about if there are differences in imaging that would tell us between hearing voices and subvocalization. That's not something
that's not your
I have.
That's not your forte. That's
No.
fine. Here's the next one. How does one determine when someone is at risk of harming themselves or others, and what does that look like? And also, how severe does it need to be before considering inpatient versus outpatient care?
Yeah, if I would say for that first part of the question, it's not the individual's job to really decide fully on their own if they're at risk of harming themselves or others. I think that's really when working with a provider is important, right? And sharing what your thoughts and feelings are at the moment, and they can help you to decide, is there a concern for imminent risk? We know there are such things, as you already mentioned, intrusive thoughts that they can involve self-harm or harming others. It doesn't have to necessitate that someone is needing to go to a hospital. So generally what we're looking for is, the term imminent is really important here. So is someone planning to act on something sometime in the near future? Is there a plan associated with it? Are they thinking about the specifics of how they would harm themselves or others? Have they specifically laid out intent of, I'm going to do it this way on this day? That will generally tell us that there is more of a risk associated. I think also if someone, lives with parents or loved ones or roommates even that they trust and can have honest conversations with this about, that's helpful to decide, am I safe to still remain at home right now, or do I need to go to an emergency room or to the hospital? And that can be helpful, having those social supports, like I said, to be able to lean on. How severe does it need to be before considering inpatient versus outpatient? It's really variable. There's a large variety in the hospital setting when it comes to levels of risk and levels of severity. So part of it is what you're comfortable with. If your goal is to stay out of the hospital as much as possible and you want to be, outpatient, speaking that and being honest with your providers and really trying to say, my goal is, to remain out of the hospital. What are things we can work on to help keep me out of the hospital, type of thing. I didn't mention it, but between hospital and clinic, there's a few other levels of care, like partial hospitalization programs or intensive outpatient programs that can be helpful at providing that more support than maybe the clinic, but not as intensive as like being in a hospital.
Thank you. Next question is, we're back to substances. The person is asking how to convince their mom that smoking marijuana is extremely harmful for their schizoaffective disorder, and is CBD without THC proven to be, to help reduce or eliminate the psychoactive effect of the marijuana.
Yeah, so the first part of the question, unfortunately, we can't force someone to stop using a substance. And, the majority, I'll say that the majority of the folks I work with, both in the clinic and the hospital, are using marijuana. It's a very common substance for people with psychosis to use, partially because they'll notice an anxiolytic effect oftentimes when they're using marijuana. And we know that psychosis can be a very anxiety-provoking experience. And so it makes sense that they would want to use something that helps to reduce that. I would say providing support to your mom and really saying, hey, I'm worried about you. I'm worried about what this substance may be doing. I've learned that it can worsen symptoms, and I wonder if maybe that's something you've thought about. Is it something that you would consider cutting back on? Sometimes even in my practice, what I'll do is say, like, why don't we try a little experiment where maybe you don't smoke for X number of days or weeks, whatever they're willing to buy into, and really say, let's keep track. Can you keep a journal of your symptoms? And let's see if you've noticed that your symptoms actually do reduce when you're not smoking. Are they worsening when you are regularly smoking? So they can really see the data themselves, and it's really the evidence of that they can gather themselves is what's going to best convince them, rather than the family member, the doctor, the therapist. They need to be able to really see it for themselves and understand why it's important. Your other question, yes, it's less risky to use CBD products. I still don't recommend CBD products to folks. I would rather them use other strategies to manage whatever it is. It's anxiety, helping promote better sleep. I think there's other healthier strategies. But if we're choosing between the two, I would use a CBD product that doesn't have the active THC. But again, this is so common. I mean, the majority of the patients I'm working with, these are topics that we have conversations about.
I'm sure they are. Another question is psychosis a certain period of time? Can it last for weeks?
Yeah, psychosis is really just that constellation of symptoms. The definition of psychosis doesn't include like a specific time period. So again, psychosis is not a diagnosis in and of itself. A brief psychotic disorder can last a day, can last a few days, a few weeks. But we also know that on the other end of the spectrum, something like schizophrenia can last years, decades, a lifetime, the rest of someone's life, right? So there's a huge variety in how people experience psychosis, but people can also experience psychosis that may occur, again, just one time, one day, and that's it, never again.
Another question is from a sibling. As a sibling of someone struggling and recently completing a partial hospitalization, how do you help them when you fear psychosis and they are lying to their care team?
Okay. So if a loved one is concerned that psychosis is present and they're concerned that the patient may be lying to the care team, again, I think it comes to going to your loved one who's the patient and saying, I'm noticing these things. I'm worried about you, providing support and just general, I'm here for you. I want you to be well and feel well. And I'm concerned that if you're not being fully honest with the care team, that you may not get the treatment and the help that's going to be most appropriate for you. There's a lot of reasons why people lie or minimize their symptoms to us. And a huge part of that is that the stigma associated with psychosis, right? They may feel that we or people around them are going to see them as quote unquote crazy. There's a lot of fear around being forced into a psychiatric hospital. And so people will say, I don't want to explain or describe these symptoms because I just know that they're going to think I'm crazy and stick me in a psychiatric hospital and force these medications on me. That's something I hear a lot. So some of it just has to do with really trying to reduce the stigma and just promote general support. Like, the loved one could just go to them and say, I just really want you to feel well. It doesn't seem like you're feeling well right now. And I want to help, you with getting the treatment and care that you need. Ultimately, though, it's up to the individual, right? If they're not ready, if they're not feeling like it's time for them to get the help or support, and there's no, safety concerns that would necessitate they need the care right now, that, I think it's up to them.
Right, the next question is, how is it treated with, how is neuroleptic, and excuse me if I get all this wrong, neuroleptic induced deficit syndrome, how is that treated after someone is injected with Invega Sustenna?
So a neuroleptic is a term that it can be used to describe antipsychotics. And so I believe what the person may be referring to is if somebody's received Invega Sustenna. Invega is an antipsychotic in that second generation class, and Invega Sustenna is a long-acting injectable antipsychotic. So if they're saying that they or someone has experienced side effects due to the antipsychotic Invega after receiving Invega Sustenna, it depends exactly on what the side effects are that you're trying to treat. Unfortunately, after someone's received a long-acting injectable, we can't remove it. So we can't take the drug out of their system. We can use other medications to help reduce the side effect burden they may experience. But that's another reason why it's really important that they're tried on the oral form of the medicine first, to make sure that they are tolerating it, that they're not having any serious side effects, that it's effective for them before they get that injection. But it depends exactly on what they're experiencing.
Okay. We have time for one or two more questions. One of them is there any advice you can give for a situation of complete non-compliance and poor insight?
I would say that this is one of the most challenging, if not the most challenging part of my job. That I see this, and it's really heart-wrenching because, we want to be able to help folks reduce symptoms, and allow someone to, be on a positive path to recovery. But if the individual doesn't have any insight and is not at all engaged in their care, it becomes really, really challenging. There are methods in the hospital setting where we can enforce treatment, but that's limited to just the hospital setting. Ideally, in those situations, they may receive enforced treatment. Again, it has to be that there's imminent risk of harm to self or others that would allow there to be enforced treatment. There's obviously a lot of legal oversight with that to make sure that we're doing right by patients before enforcing treatment. But if the idea is that if they do get some form of treatment, even if it's enforced in the hospital setting, maybe symptoms reduce enough, maybe they start to develop some insight into what's going on and what their symptoms are, that when they leave the hospital, they're more likely to continue to engage. We can also provide folks with a long-acting injectable in the hospital setting that then helps to provide some coverage, right? So then maybe they're not having to take that medicine every day. Maybe they already have the antipsychotic in their system via the injection. And then it's just time, truly. Sometimes it's a few repeated hospitalizations before someone can recognize the impact it's having on their life and see, hey, I'm wanting to do something different. This time I'm going to try that medicine, or I'm going to try that therapy they've been talking with me about.
Okay. One more question, and this has been a common question that I get, that we're getting in the chat, and that NAMI Davidson it gets a lot. Do you take appointments with family members when someone is not in your care, meaning as a consultant of what they should do? If their loved one is suffering but will not get the care, do you take appointments, or does anyone else take appointments to talk to the caregivers about strategies?
Yeah, I work personally just in the hospital setting right now, so
Mhm.
I don't take any appointments personally, but we do have plenty of providers in the clinic that, see folks by appointment. And it's primarily our psychotherapists that do a lot of like the caregiver support. And so we do have psychotherapists here who will book appointments with specifically the caregivers of someone with psychosis to work on, um, providing the psychoeducation to them and the support to them so that they're then able to turn around and be a better support to their loved one going through psychosis. It's there's such a need for that, and I do see that there's a gap in the field and helping caregivers going through this.
All right. Well, I'm going to draw our questions and our presentation to a close to respect Dr. Fall's time. Dr. Fall, I want to thank you for taking some of your off hours to speak to us at NAMI Davidson and the general community. As I said earlier, this will be on our YouTube channel, the audio version. Dr. Fall will be sharing the presentation with me, and I'll email all registrants. I do want to, before we end the evening, remind you all that this is the end of the fiscal year and we do our planning that way. So I encourage you, if you have any topics you would like us to address in our virtual education sessions, please reach out to me at outreach@namidavidson.org. That is the best way to get a hold of me. I keep my email up a lot more than my phone. But we are taking suggestions. If we can find a speaker in our area or someone who would be willing to do it from out of state virtually, we do that. But we've had suggestions even, it doesn't necessarily have to just be about mental health conditions specific. We have had requests to do sessions on dissociative identity disorder and borderline personality disorder. But we've also had suggestions of have someone come out and talk about the difficulties and challenges of dating when you have a mental health issue, how to address that with a new partner when you're out on the dating scene. So we are open to all suggestions. If we can find a presenter, we will definitely put it on our schedule. We do have one already on our 2024-2025 education session schedule, and that is Tuesday, October 1st. We have Dr. Joseph Pandit coming back to us, I think for the 4th year that I've been here. He actually did a dual education session with Dr. Fall a couple falls ago, Dr. Fall. But again, on Tuesday, October 1st, Dr. Pandit will be doing one on understanding psychiatric medications, but we are still adding to next year's next session, so we are still open to suggestions. So I want to draw the evening to a close by thanking Dr. Fall, thanking you all for taking time out of your Wednesday night and helping promote NAMI Davidson programs. So again, thank you very much, Dr. Fall, and thank you all for coming.
Thank you.